It's a pleasure to be with you all today. And so Dr. Tony and I have the bacteremia and sepsis portion of our boot camp series. And so these are kind of core topics, and particularly with regard to bacteremia, it is something that we see a lot in our day-to-day practice as infectious disease specialists. My lecture today is meant not to be all-encompassing. Obviously, there's a lot more topics here to consider. These are kind of basic topics about the management of bacteremia and how we approach these patients. And blood cultures are among the most commonly ordered laboratory tests. I think many of us can reflect when we're on inpatient duty, we may order several sets of blood cultures on patients per day. And in a prior series, about 1 in 10 blood cultures are positive. And although gram-negative organisms were once the most predominant pathogen that we saw in hospitalized patients, because of the onset of intravascular devices, prosthetic devices, patients on dialysis and so forth, gram-positives are now the leading cause. And the most commonly isolated pathogen, no surprise, is coagulase-negative staphylococcus. Blood cultures have a profound effect on the hospitalized patient and on the hospital as well. The mean infection-related cost estimated at more than $67,000 for patients with hospital-acquired Staph aureus bacteremia and a prosthetic device. And even if you're coming from the community, the cost is considerable, about $38,000 for community-acquired Staph aureus bacteremia. Again, the cost difference there a lot of times relates to extension of a hospital stay and having all the complications of having a prosthetic device and requiring explantation and replacement and so forth. Dialysis patients also, something like MRSA bacteremia has considerable cost expenditure, and not just in sheer dollars, but also morbidity for the patient. And we all know intuitively that positive blood cultures are a significant reason why patients stay longer in the hospital, an average of 4 days or more. What you all may or may not be aware of is that since 2017, MRSA bacteremia is part of the CMS Hospital-Acquired Conditions Reporting Program, tying the incidence of certain diagnoses to hospital reimbursement. So, and I've listed those HAI, hospital-acquired infection diagnoses, on the right of the slide. So if you have a MRSA bacteremia or a central line-associated bloodstream infection, your hospital will be assessed for these diagnoses as being complications. So hospitals have a significant stake in preventing these conditions, including MRSA bacteremia. And if you have a bacteremia, of course, your surgery may be canceled. You may require explantation or replacement of a line. You're going to require additional costs even beyond the hospital stay due to extended courses of antibiotics, and there's also additional infection expenditures as well. Now, the saga of positive blood cultures, good morning, Dr. Tony. The saga of positive blood cultures begins with blood culture collection. And at our facility and others, we track contamination rates for quality improvement purposes. And at my facility, for example, contamination rates typically 2 to 3%, sometimes higher, sometimes lower than 2%, but 2 to 3% is on average. I think Dr. Tony will agree. And the typical organisms we see in blood culture contamination, coagulated staph, Corynebacterium, and so forth. And most blood cultures are collected in the ED, and we know intuitively that the ED kind of presents the paradox of blood culture collection in that there's less than ideal conditions, but at the same time, there's a lot of time stress to get these blood cultures collected and get these patients to have a disposition for wherever they need to go. So here's a typical patient getting blood cultures collected, and we can see that this appears to be a young patient, healthy, young appearing arm. You see some veins that appear that they can receive venipuncture. The phlebotomist is applying an alcohol wipe and then some betadine, inserting the butterfly IV and placing in the blood culture bottle. These are kind of the ideal conditions. Doesn't, at least from the photo, appear to be very rushed or stressed. But we know a lot of times that this is the ideal, and more likely than not, we're going to be seeing patients who have a lot of vascular fragility, a lot of laxity of their skin, maybe veins that have collapsed, and maybe this can't be done in the most time-efficient manner. So a lot of times blood cultures are collected in a less than ideal situation, less than ideal than what we see here. And so as a response, there's a lot of attempts either through technology or training to reduce the contamination of blood cultures. So a lot of hospitals, not sure about this one, but certainly at our facility, utilize what are known as initial specimen diversion devices. And this is one on the right, Sterapath. And what they do is they attempt to reduce the potential for blood culture contamination by siphoning off the first 1.5 to 2 cc's of blood, where much of the contaminant is believed to occur, and then to permit all the blood that needs to be collected after that to be captured into the blood culture bottle. So I know that we've had some success with reducing blood culture positivity with these types of devices. And then where does the saga of blood cultures go to from there? Well, through our blood culture systems. And Dr. Tony and I are have a lot of recall about the manual blood culture systems that we used to use before automation became the accepted standard. And so in the old days, you had a manual blood culture incubation system and a series of racks, and 1 or 2 times per day, your blood culture technologist would open the machine, pull out the racks, and check each of the blood culture bottles individually for signs of blood culture growth. There might be cloudiness there, slight color change, those sorts of things. And if the technologist noticed that the blood culture bottle appeared to be having growth, then they would pull out some of the blood, place it on do a gram stain, and if it looked like the blood culture was positive, it would be called at that time, and then they would plate the media out and do the blood culture processing. So we would either hear about positive blood cultures, say in the mid or late morning or the early afternoon. That was the standard. So now blood culture systems are fully automated. And what that means is they use in most cases, a colorimetric system with a sensor. And so if you invert a blood culture bottle, you'll see that sensor at the bottom of the bottle. And they read blood culture growth continuously. So you can get a blood culture called at any time. So this is continuous monitoring. This is more reliable because it uses a sensor. It permits high volume testing, less technologist involvement, at least in this initial positivity. And so the main 2 systems that I'm familiar with are the Bactec and the Microscan. So at a facility across the street, we use the Bactec system and estimated cost of blood culture between 96, around $100 to $400 on average. So your blood culture is called positive, and where do you go from here? Well, in the old days, we would set up a plating on a culture media, it used to take from anywhere from 24 to 5 days for your blood culture isolate to be identified. But the latest advancement in blood culture processing, of course, is our mass spectroscopy with MALDI-TOF. And so, whereas previously we would subculture, gram stain, and go to a biochemical identification panel, now you can, through this rapid identification protocol with MALDI-TOF, have an organism identification in as little as 10 to 30 minutes. And this is one of the main ways that we do rapid identification of positive blood cultures. The downside, of course, for your susceptibilities, you still need to do more standard testing. So you get called with a positive blood culture. What's your initial assessment? What are you looking for? After your initial period of panic is over, you want to ask, what's the gram stain results? Is it a gram-positive cocci? Is it a gram-negative cocci? Is it a gram-negative rod? Are there single versus multiple isolates? Because we all know that a single positive blood culture bottle is maybe less specific for a true bacteremia than if you have the same isolate in all 4 bottles, right? So how many bottles are positive? Is the blood culture bottle that's growing from the aerobic bottles or the anaerobic bottles? And it seems like we still have plenty of issues in the modern day with labeling blood culture bottles, right? Where did this come from, this positive blood culture? Did it come from a peripheral stick? Was it from port number 1 or port number 2? Was it from the dialysis catheter? A lot of times that information can be very helpful. And sometimes it requires our sleuthing skills to figure out. And also, what is the time from collection to positivity? So we all know that the inoculum in a blood culture bottle really matters, right? So if you have a smaller number of organisms that get inoculated in a specimen, let's say from a contaminant or from a pathogen that really isn't in high quantity in the blood system, we're going to tend to require a longer period of growth. But on the other hand, if this is a true positive blood culture and there's a high inoculum from the blood that gets placed into the bottle, generally speaking, it's going to be called positive a lot sooner. So there's a lot of conditions that are linked to having bacteremia, right? What are some comorbidities that tend to increase your likelihood of bacteremia? You want to think about chronic illness, malnutrition. Patients are on TPN. There are certain organisms that are associated with positive blood cultures. Does a patient have a prior bloodstream infection history? And what did they grow on those occasions? And also, patients who are at the extremes of age tend to have less than optimal immune system function and may be more susceptible to bacteremia. Also, we want to think about our immunocompromised patients, like those who have stem cell transplantation, CAR T, and so forth. Patients with immunodeficiency, particularly who have high-grade neutropenia, are at highest risk. So you want to think about those where your neutrophil count is less than 100. And generally speaking, hematologic tumors have a higher risk of bacteremia than solid tumors. These are some other considerations. What are the circumstances of collection? Was this collected in the ED? Was the ED having some issues this month, or the UCC for that matter, having some issues this month with blood culture collection? Is there a lot of staff turnover? I mean, after all, these days we're in the, what as they call it, the great resignation, right? Everybody wants to move on to a new job. So phlebotomy is actually a highly skilled technique to learn. You need to know how to collect blood in the most efficient and sterile manner, but with the high turnover we see these days, it's not always possible. Does a patient have a medical device, an ICD, a central intravascular catheter, the presence of a prosthetic device? And do they have compromised skin or GI integrity? Are they a burn patient? Do they have skin conditions like Stevens-Johnson's? Do they have interruption of mucosal barriers? You know, here at this facility, a lot of times patients have ablative chemotherapy. Their GI tract becomes less than totally intact, and they get gram-negative bacteremia from a GI source. And you want to think about pre-test probability of bacteremia when you order blood cultures. These conditions have a high pre-test probability of bacteremia. So if you're thinking about them, you may want to get a blood culture ordered or a set of blood cultures ordered, because chances are, if the blood culture is positive, it may correlate with the presence of an infection due to one of these conditions. So discitis, vertebral osteomyelitis, there's a high pretest probability of bacteremia. And you want to think about that in reverse. With somebody with, for example, Staph aureus bacteremia has a positive blood culture, could they have discitis and vertebral osteomyelitis as well? Meningitis has a high pretest probability. Septic joints, patients with catheter-related bloodstream infections, to name a couple on this list. Conversely, these patients have a low pretest probability of bacteremia. So if you have somebody with uncomplicated cellulitis and you want to check blood cultures, chances are probably a lot lower that they're going to have bacteremia. Lower urinary tract infections like cystitis, less likely associated with bacteremia than pyelonephritis, for example. CAP and HCAP don't often present with bacteremia. And early fever after surgery, and also transient fevers, not often associated with bacteremia. So these are some characteristics of a true positive blood culture. Single pathogens correlate more with true bacteremia than multiple pathogens, and also pathogens that are consistent with typical blood culture organisms. So if you see a Staph aureus growing from a blood culture, or strep or enterococci, more likely to be associated with true bacteremia rather than pathogens that are not normally associated. And we'll go over those in just a second. Also, multiple positive cultures with the same pathogen. So 4 out of 4 bottles for Staph aureus. I would be concerned, right? I think all of us in the room would be. And also clinical symptoms consistent with bacteremia like fever or septicemia. Also, does the patient have bacteremia risk factors like an intravascular catheter or an obvious GU respiratory or vascular source? In contradistinction, these are the characteristics of a false positive blood culture. Think about these. Was there a prolonged time to culture positivity? Was the culture called 72 hours later? Was it a polymicrobial result, including some organisms that are normally associated with blood culture contaminants? So you have, a positive blood culture that's reported in 1 bottle, for example, that has Corynebacterium and coag-negative staph, in a patient without a central venous catheter. That sounds to me like it's more consistent with a false positive blood culture. In a patient who's asymptomatic too, no fever, signs of sepsis, and so forth. Dr. Tony will outline those signs of sepsis in the second hour. So the following are blood culture pathogens that are frequently contaminants. Coag-negative staph. You want to think about there's a lot of different coag-negative staph strains. Epi, capitis, hominis, think about those being frequently contaminants. Corynebacterium bacillus can cause true bacteremia, but usually there's a factor associated with it. A central vascular catheter, for example. You may think about Corynebacterium jacam or a device. Bacillus species occasionally can be associated with a Lyme-related infection, but in the absence of any indwelling device, these are frequently contaminants. Same thing with Propionibacterium or Cutibacterium in the absence of a suspected source. Micrococcus as well. Viridin streptococci are a little bit more challenging in that, Viridin streptococci can cause endocarditis, of course, but they can also be blood culture contaminants if there's low suspicion for a primary source. On the other hand, these are not usually or never contaminants. So think about obviously Staph aureus or streptococci, like Group A strep or Group B strep, strep pneumonia, Clostridium, Listeria, Candida species should be taken seriously. Cryptococcus, of course, sometimes can be confused on blood culture for Candida, but is obviously not or never a contaminant. And then we have our gram negatives, which are listed there. Pseudomonas aeruginosa always needs to be taken seriously. Similarly, Neisseria strains like gonorrhea, meningitis, and if you get growth of anaerobes from a blood culture, generally speaking, not a contaminant like Bacteroides. I'm going to touch on a few gram positive and gram negative pathogens that bear some further mention. Again, for staph epi or for coagulase negative staph, yeah, you have a lot of coag negative staph strains, staph epi, staph conii, staph intermedia, staph saprophyticus. Generally speaking, unless you suspect a source, think about it as a contaminant. The exception, of course, is staph lugdunensis because that has clumping factor. It shares it with Staph aureus, and so it has similar pathogenicity. So if you see a Staph lugdunensis, treat it like Staph aureus. Staph aureus, of course, a lot of times the first question that we ask is this MRSA versus MSSA? And it seems like, at least in my experience, more recently, we see a lot more MSSA occurring in the community, and we tend to see MRSA occurring in the hospital. If you had asked me that 10 years ago, there was a discussion about community-acquired MRSA. And we still see some community-acquired MRSA, but generally speaking, maybe through antibiotic stewardship and other interventions, we are seeing more MSSA infections. Could have to do with, just the natural biodiversity of Staph aureus these days. Streptococcus species, viridin streptococci include all of these strains here. And again, if you're looking at blood cultures and you have positive growth of viridin strep, here's some things I would ask. Is this one blood culture bottle? Is this a patient at risk for endocarditis, or do they have another defined source? And, do I need to screen for an endovascular infection? Is this a blood culture that is repeatedly positive, or just one that's in one single bottle in an asymptomatic patient? That's going to help you determine whether viridin streptococci is a true pathogen or a blood culture contaminant. And Enterococcus, of course, Enterococcus fecalis being more associated with community-acquired infections versus Enterococcus faecium, more a hospital-acquired pathogen. But again, those are general distinctions, and cross positivity in the hospital versus the community can occur. And Corynum bacterium and bacillus, we said, typically speaking, are frequently contaminants unless you have a indwelling device or some other reason to suspect they could be associated with some implanted hardware or prosthetic material. Listeria, of course, you want to particularly worry about in certain risk groups like pregnant patients, the elderly, not typically, I would say never a contaminant, and you want to take it seriously. And although, we tend to see more gram-positive bacteremias these days, I would argue that gram-negative pathogens are more of a management concern because of the high incidence these days of gram-negative resistance. So when you have a positive blood culture for an enteric bacteria, you have to ask yourself, is this an AMP-C, ESBL, CRE producing strain? What do I need to do to ensure that I treat this appropriately, at least initially, because of the high association between gram-negative bacteremia and significant morbidity and mortality. And generally speaking, you want to look at what a patient has grown in the past and let that be a guide. Is this a patient who's had a history of ESBLs in the past? Do I need to cover them with with an appropriate antibiotic like a carbapenem and so forth? Similarly, Proteus, Providentia, Serratia also can be pathogens associated with antibiotic resistance. Pseudomonas bacteremia, very challenging to treat, particularly when it's multi-drug resistant. And if you have Acinetobacter, Stenotrophomonas bacteremia in your hospitalized patient, maybe think about antibiotic stewardship, infection control concerns, and so forth. So, and of course, the modified Hodge test isn't really used anymore. I just stuck that up for photo value. So what are Sentinel bacteremias? The presence of these pathogens should make you think about something else. So Clostridium bacteremia, you want to think about a skin soft tissue or GI source. So does a patient have a crush injury? Are they at risk for necrotizing skin and soft tissue disease? Or do they have the potential for a GI malignancy, like with Clostridium septicum? Same thing with Streptococcus galliticus, formerly known as Strep bovis. You want to think about an association with GI cancer. Burkholderia is significant. If you have a Burkholderia bacteremia, you want to ask, is this Cepacia, hospital-acquired pathogen, or Burkholderia pseudomallei, which is you need to notify your lab that you could have a case of melioidosis. You want to look at it in the same clinical context of some association with melioidosis. And again, the lab needs to know about it because contamination or infection can occur if not handled properly. And Listeria, the three categories are immunosuppressed patients, elderly, and particularly pregnant women need to be especially concerned about Listeria because of the high risk of morbidity and mortality from Listeria sepsis in a pregnant patient. So again, I know that today we're talking about just the basics, so I don't want this to seem too simplistic, but these are practical steps for managing a blood culture. Again, you want to establish whether it's true bacteremia versus a contaminant. A lot of times we're relied on to make that call. And so for those of you who haven't been in this place for very long, who are earlier on in your infectious disease journey, it just takes experience, right? And then also your understanding of the facts and the ability to look at the case and determine whether it's true bacteremia versus contaminant. But once you've made that decision, if it's false, if you don't think it's a true bacteremia, you want to assess if there's reasons for contamination. Is this a patient with poor skin integrity or hygiene? Where was this collected? Has the collection technique traditionally been good in your center in recent days or weeks, and so forth? And you want to document the risk factors and consider repeat cultures. If it's a true bacteremia, you want to assess for sources. Is there an indwelling device, maybe a Foley catheter? Could there be a skin or soft tissue source? Is this a burn patient, for example, with compromised skin integrity? Is this a patient with profound neutropenia who has ablative chemotherapy and could have a bacteremia from a GI source? Is there another septic focus? And then you want to determine the need for treatment. Remember, it's our patients with gram-negative bacteremia that have the highest acute mortality. So coverage for those patients has to keep that in mind and has to be rapid. Staph aureus bacteremia has the highest overall mortality, of course, and so always needs to be taken seriously. And you need to, at least if you don't have the specifics of Staph aureus bacteremia back, you need to consider, do I need to cover this patient for MRSA, or is this more likely to be MSSA? And of course, the MALDI-TOF is not going to tell you that. You need to wait for your biochemical determination. And Pseudomonas aeruginosa also has very high morbidity from infection. And so that needs to be kept in mind. If it's true bacteremia, you want to address the underlying focus. Wounds need to be debrided. Osteomyelitis needs to be debulked. Infected devices should be explanted in the appropriate clinical setting. You want to also rule out septic thrombophlebitis. Sometimes we see patients getting a DVT that's with a septic component, and that's why they have their bacteremia. And you want to rule out an endovascular focus for pathogens that are associated with endocarditis. So if you have a patient with E. coli bacteremia, again, I would be less concerned about an endovascular focus. But if you have a patient with Staph aureus or Enterococcus or strep, or somebody with a prosthetic valve, or somebody with a history of valvular disease or a murmur, then obviously you want to rule that out. And you want to promptly begin antibiotic treatment. Basic principles about antibiotic treatment. You may need to kind of pull out your broad spectrum coverage until further blood culture results are available. But then when you have your susceptibility results, obviously in the interest of good antibiotic stewardship, you want to narrow your focus, narrow your coverage to the specific pathogen. You want to use pharmacokinetics to your advantage. That's where our wonderful ID clinical pharmacists come in. They are always helpful to us with recommendations and the best possible dosing. I'm not pandering to anybody in the room, of course, but and some antimicrobial classes are preferred in bacteremia than others. So under good, I've placed antibiotics that traditionally have characteristics that are ideal for bacteremia. So glycopeptides, daptomycin, beta-lactams, carbapenems all get good intravascular levels, and they have advantages for the treatment of intravascular infections for bacteremia. But on the other hand, these are less ideal classes of antibiotics for the treatment of bacteremia. For example, quinolones, they get good concentrations within the blood, but because of quinolone overuse, are you sure that your ciproflox is going to cover that E. coli that's in the blood? So probably not the most ideal agent. Similarly, tetracyclines like doxy and tigecycline, are highly protein bound, maybe not the best for intravascular infections. Trimethoprim sulfa, I would say, kind of has more of a limited gram-negative spectrum of action, and so it's not the first thing I would go to if I were treating a gram-negative infection, and perhaps not the first thing I would go to if I was treating gram-positive bacteremia. And the oxazolidinones tend to be, are reputed to be more bacteriostatic than bactericidal. So I would hold back the linezolid for treating Staph aureus bacteremia necessarily. At least I would do that versus another agent like vancomycin or daptomycin for that matter. It seems like one of the more difficult things that we confront is how long do we treat bacteremia? And there's a lot of factors to consider there. A lot of times, if you're unsure, look it up. I find that UpToDate is really good at recommending durations for treatment of a lot of syndromes. And pathogen-specific factors apply. If you have a gram-negative rod bacteremia and it's due to E. coli, you could probably treat that for 7 days. But if you have a Pseudomonas aeruginosa bacteremia, I think a lot of clinicians would feel uncomfortable with that short a duration. They want to treat longer for an uncomplicated bacteremia, that is. And what is the role for oral therapy, too? We'll touch on that in just a second. So just some pathogen-specific comments to make. For Staph aureus bacteremia, again, this is one of our big pathogens of concern, right? And we have to think, is this a primary bacteremia, maybe due to an intravascular focus, or is it a secondary bacteremia? Does the patient have a discitis or an abscess or something that is causing bacteremia as a secondary syndrome? Is it complicated versus uncomplicated? Because complicated infections require longer treatment and maybe additional management versus uncomplicated infections, which may just require some simple source control and removal of the device. Is there a need for imaging? Does this patient need a TE, for example? And does the patient have a distant focus, like vertebral osteo or discitis, or an epidural abscess, for example? And what indwelling devices does the patient have? Does the patient have a ICD, for example? Simplest way I like to check, go to your x-ray reader and look at a chest x-ray. I mean, you don't even have to approach the patient. You can still determine that. And also that applies to lines as well. And we know that the highest long-term mortality is from Staph aureus bacteremia. Enterococcus bacteremia, think about community-acquired infections with E. faecalis. These tend to be ampicillin and penicillin susceptible. Faecium, generally more associated with hospital-acquired infections or hospital exposure, often resistant to vancomycin and the beta-lactams. And you want to think about biofilms playing a role in persistence of this pathogen. How many people have in the room, raise your hand, have seen a pneumococcal bacteremia? I see a couple of hands. And that can be scary if you have a patient with a pneumococcal pneumonia. Oh, my patient has pneumococcal bacteremia. I haven't seen this very often. Well, actually, pneumococcal bacteremia clears pretty quickly and is very susceptible to antibiotic treatment and only requires a short course. So this one is more scary than perhaps it should be. And the enteric bacteria, it seems like these days we're going more towards 7 days of treatment than 14 days. I think that's a good thing. Of course, you need to ask yourself, does this patient have risk factors for AMP-C production in their gram-negative enteric bacteria, ESBL or CRB? Do I need to, can I start more first-line coverage? Does this patient need coverage with a carbapenem? And also, what's the indication for aminoglycosides in enteric bacteremia? And as far as do I need to repeat blood cultures for clearance, I think that's something that has become less in the canon of gram-negative positive blood culture management, because I think there was a recent study, and I don't have the author name, but they studied 500 cases of gram-negative bacteremia. And out of those, I think 77% had positive blood, had repeat blood cultures checked, and only 8 out of the 500 actually had positive blood cultures for a gram-negative rod. So a lot of times, uncomplicated gram-negative bacteremia doesn't necessarily need repeat blood cultures to document clearance. So I would say repeat your blood cultures selectively, because remember, when you repeat blood cultures, they have to be followed up. There's a cost associated with that, and you need to know when it's appropriate to do so and when not to. So for uncomplicated gram-negative bacteremia, you don't necessarily need to repeat the blood cultures to document clearance. But on the other hand, if I have a Staph aureus or an enterococcal bacteremia, I certainly would want to document clearance, or a Pseudomonas bacteremia for that matter. And I'd love to hear others' comments about that. Pseudomonas, difficult to manage, 2 weeks minimum, IV preferred, and potential endovascular pathogen. And if you have positive blood cultures for endocarditis pathogens like Staph species, viridin streptococci rather, and enterococci, you want to pursue that with echocardiography. TE may be necessary, and these patients will need prolonged therapy if they have endocarditis or an endovascular infection, and surgical consultation when advisable. We've had a lot of discussions about that at our facility in the last few months. So when is double coverage needed? I think this is something that clinicians ask a lot about. We get questions about this from people who consult us. So there are several instances where double coverage may be needed. For example, if you have severe gram-negative bacteremia sepsis, is it initially appropriate to add an aminoglycoside to clear the bacteremia more quickly? Also to provide a little bit of insurance that you're not dealing with a multi-drug resistant strain. I think that many clinicians will say, yes, that's appropriate in certain circumstances, with the idea, of course, that you want to narrow coverage as soon as you get those susceptibilities back. And if you have a risk of multi-drug resistant gram-negative bacteria until susceptibility results are known in a significantly ill patient, then yes, that's appropriate. Also, bacteremia with enterococcal or streptococcal endocarditis, dual coverage is in the guidelines, especially non-susceptible or prosthetic valve endocarditis. Can anyone in the room think about another circumstance where you may need to double cover a patient? Let's expand the focus for anything. So when is double coverage necessary.
CNS infection.
CNS infection, it may be appropriate in some circumstances. What I was thinking about more is, yeah, the addition of, let's say, clindamycin in a patient with necrotizing infection. Another circumstance would be like Clostridium difficile, severe Clostridium difficile disease, where you start your oral vancomycin and maybe IV metronidazole. So there are other areas where, or for example, if you're adding anaerobic coverage, adding metronidazole to cefepime, for example, you want to double cover. So there's, additional need for double coverage in some clinical syndromes, but for bacteremia, there's a limited number of indications. And when do you narrow therapy? When you get those susceptibility results back, the mantra that I go by is, if you have your susceptibility results back and you know that a single agent, that monotherapy is effective, narrow your spectrum to monotherapy immediately. There really isn't any reason to double cover. Patients should respond. And again, I'd love to hear others' comments. And so in the modern day of getting patients to have a disposition faster and in the interest of good antibiotic stewardship, you have a case of bacteremia, when can you convert IV to PO? So if a patient's clinically improving, source control is achieved, they're able to take and absorb oral antibiotics, and the oral agent has adequate oral bioavailability. So you have a patient with E. coli bacteremia with a susceptible strain. You start your IV therapy, you get your susceptibilities back. It's susceptible to levofloxacin or ciprofloxacin or Bactrim. They're clinically improving. You can go ahead and switch those patients to oral therapy if the agent has adequate oral bioavailability. So obviously for your gram-positive bacteremias, things are a lot more difficult. We don't have a lot of agents with high oral bioavailability for gram-positive infections. So you have to take that with some caveats. But nevertheless, these are general guidelines. And what are post-treatment considerations? You want to reduce risk factors for recurrent bacteremia by minimizing line use, eliminating unnecessary implanted devices. I mean, that's really one of the major things we do, right? Prevention. We want to look at a case and see how we can prevent recurrent bacteremia. If a patient has an ICD or has GU stents or has vascular grafts, is source control going to be needed? Do those devices need to be explanted or replaced? We need to think about those things. And if there's an endovascular source, it seems like it's more difficult these days to get valve replacement in a timely fashion at some of our centers, but we need to push for that when it's appropriate. And sometimes I use surveillance blood cultures. So if I'm not certain that I've treated bacteremia for a long enough duration, you can repeat blood cultures in a couple weeks. If they're still bacteremic, then obviously your initial course was inadequate and you need to look for whether source control was really achieved. These are some of the resources I use for managing bacteremia. Again, the Sanford Guide, great app available for your smartphone. Some swear by the Johns Hopkins Antibiotic Guide. That's great as well. Up to Date is really good with bacteremia and duration, and that's one of my favorites. So these are my summary points, and again, I think just developing the confidence in managing these cases is something that you will do because we see it so often, and you can become experts in the treatment and assessment of bacteremia in a very short period of time in your career and day-to-day practice. So with that, I'll stop and I'll take any questions. Thank you all very much.